Hello, my name is Tracy George. I'm from the University of Utah and ARUP Laboratories, and today I will be discussing the hematopathologist's role in the diagnosis of acute myeloid leukemia. So let's talk briefly about classification of AML. I've told you how you diagnose it, but how do you classify it? So back in the 70s, we had the French-American-British classification, which was largely focused on morphology. This was a product of an international cooperative group of 7 experts that used morphology and some cytochemistry to standardize the diagnostic criteria for acute leukemia. In 2001, the World Health Organization came out with a classification that started to take into account cytogenetics and as well as molecular features of acute leukemia. This was further refined in 2008 and then in 2017. The FAB classification focused on AML M0s to M7 based on morphology and cytochemistry. In 2017, we have now focused on these broad categories, and there are multiple subtypes of AML within each category. So there's AML with recurrent genetic abnormalities, AML with multilineage dysplasia, the therapy-related myeloid neoplasms, myeloid proliferations associated with Down syndrome, and then AML not otherwise specified, where you refer back to that original FAB list. This WHO classification defines entities that are biologically homogeneous that have important clinical relevance. This allows us to perform risk stratification by using either the European Leukemia Net or the NCCN Guidelines, which allow us with all of this information to separate patients into favorable, intermediate, or adverse categories, and this drives therapy and prognosis. Now I just want to focus briefly on updated guidelines for acute myeloid leukemia. I hope I've shown you that the laboratory testing standard of care in AML includes morphology, flow cytometry or immunophenotyping, cytogenetics, and molecular genetic studies. The College of American Pathologists and the American Society of Hematology convened a panel of experts in hematology and hematopathology to develop recommendations on the initial diagnostic workup of acute leukemia. 6 key questions were identified, and a systematic evidence review was conducted to address these key questions. 27 guideline statements were established, and grades for strength of evidence was used, and this was published at the end of 2017. These are the 6 key questions that were identified for the diagnostic workup of acute leukemia. What clinical and lab information should be available, what samples and specimen types should be evaluated, what tests are required for all patients during the initial evaluation, what tests are required for only a subset of patients, where should lab testing be performed, and how should the results be reported. One area that has been of increasing controversy is what molecular testing should be performed. And this is addressed in Guideline Statement 16, which notes a strong recommendation for testing for FLT3 ITD, internal tandem duplications, and recommendation for testing for other mutational analysis includes IDH1, IDH2, TET2, WT1, DNMT3, and or TP53 for prognostic and or therapeutic purposes. This is an algorithm to help you identify what molecular testing should be performed, where strong recommendations based on the literature are shown in green, recommendations are shown in blue, and where the literature is not clear, expert consensus is shown as in gray. So all patients should be tested for FLT3 ITD. It's recommended they should also be tested for IDH1, IDH2, TET2, WT1, DNMT3A, and TP53. If the patient at the far right has acute promyelocytic leukemia, they should have PML-RARA studies as well as coagulation studies. At the far left, if they have core binding factor AML and they're adult, they should be tested for KIT mutations, and if pediatric, they may also be tested for KIT mutations. And if they, in the middle, if they have AML other than core binding factors, acute promyelocytic leukemia, or AML with myelodysplasia-related cytogenetic abnormalities, then they should be tested for MPN1, CBP-alpha, and RUNX1. So we know that rapid treatment decisions are made in AML. And this paper by Mikhail Zakaris showed time to treatment in AML, and that the vast majority of patients start therapy 1 to 4 days after a diagnosis of AML is made. So short turnaround time is needed on these tests, and the results are required before treatment. Cytogenetic tests take days to grow. FISH tests are generally resulted in a day or two. And then we come to molecular tests. There's many different methodologies that can be performed for molecular testing, including PCR, traditional sequencing, and next-generation sequencing, or NGS. And there's both advantages and disadvantages, but increasingly we're going to larger scale NGS panels where we're examining a large number of mutations. And this often supplements the more faster PCR-based methods, for example, being used now for FLT3 and for other specific gene mutations. So I've tried to show you the laboratory testing standard of care in AML, where in morphology we need to examine blood smears, bone marrow aspirate smears, and biopsies. We need to perform immunophenotypic studies such as flow cytometry and sometimes cytochemistry and immunohistochemistry. We also need to grow the cells and perform cytogenetics, which is often supplemented by FISH testing. And it's imperative that we perform molecular genetic testing in patients, and there are now specific guidelines which recommend which genes to test. So thank you very much.